Hi, welcome to another episode of Clinical Series. This is Dr. Bharat Kumar. So let's look at this question. What does FAST stand for in imaging investigations? Basically, whenever in the case of acute trauma in casualty, that is emergency room, the basic preliminary investigation is one of the most important ones is this FAST. So what is FAST? So FAST is nothing but focused assessment with sonology in trauma. Okay, so this is FAST, focused assessment with sonology in trauma. So, what are the basic regions examined in FAST and eFAST? So, there is only little bit difference between FAST and eFAST. So, eFAST is nothing but extended FAST. Okay, so as you can see in the picture, the basic regions which are examined here is one is pericardiac region. Okay, so that is nothing but subxiphoid view. So, pericardiac. Second one is perihepatic. This is the right hypochondrium. So perihepatic. Third is perisplenic. That is left hypochondrium. And the last one is pelvic. Okay. So you can remember four P's in that order. So you can see here. So this is the order in which we are examining. So four P's. First one pericardiac, second one perihepatic, third one perisplenic, and last one is pelvic. So the main aim in FAST is to look for any free fluid or any solid organ injury, and the other things which are mainly present in these four areas. The additional thing that we are going to examine in eFAST is we are going to examine for both pleural cavities to look for any pneumothorax or any hemothorax. Okay, the additional two things which will come in eFAST is bilateral pleural cavities. So it is nothing but FAST plus bilateral pleural cavities. Okay, right. Next. So what are the main uses or applications? As I have mentioned, this is mainly useful in case of trauma. So it can be either blunt or penetrating trauma of either thorax or abdomen. Okay, right. So the another one of the main disadvantages is it cannot easily pick up hollow viscous perforation. Like it cannot say where the exact perforation is and all. It can suggest you that this could be a case of hollow viscous perforation by identifying the free fluid within the cavity. Okay, right. Next. So this is a picture showing some type of minimally invasive surgery. So, what is the type of surgery done for this patient? So, this is nothing but, as you can see here in the picture, these are the multiple ports that are inserted into the abdominal cavity. So, this is nothing but laparoscopic surgery. Laparoscopic surgery. Okay, right. What are the common surgeries done via this approach? So you can remember easily whatever the organ that comes into your mind in abdomen, all those surgeries are done by laparoscopy. Let's say, for example, laparoscopic gastrectomy, laparoscopic hepatectomy, laparoscopic pancreatectomy, laparoscopic splenectomy, laparoscopic nephrectomy. Like this, there are so many abdominal operations which are done by like laparoscopy. In addition to that, you can remember ventral hernias, like any epigastric hernia or umbilical hernia or any incisional hernia. They can also be done under laparoscopy. Okay, right. So, what are the main advantages of minimally access surgery or minimal access surgery? Laparoscopic is one of the minimal access surgeries. The other one is robotic surgery. Okay, so what are the main advantages here? In contrast to the conventional open surgery, we are making only small incision, maybe 1 centimeter or less than that. So obviously there is a decrease in wound size. Then second one is as the wound size is less, obviously the pain after the surgery will also be very less. So decrease in wound pain. So because of the less size of the wound, there will be decrease in pain. Okay, and also there can be during the surgery we are using a camera which is having so much magnification, so we are having improved visualization during the surgery. Then because of the less incision, there is less chance or there is reduction in wound infection, and also there is less chance for dehiscence or bleeding, etc., etc. Because the wound is less in size, there will be early postoperative recovery and patient can be discharged early. So obviously the ultimate point is there will be hospital stay will be less, short hospital stay. Okay, all right. So this is the advantage of minimal access surgery, right? Next. So what are the different types of burns? As you can see here, it's a case of thermal burns. So what are the different types of burns means? First one is thermal burns. Second one is electrical burns. Next is chemical burns. Last one is radiation burns. So based on the mechanism, these are the different types of burns we have. And again in thermal you have like basically when hot liquid falls on the skin, it causes scald. And when directly the flame is burning the body, that is flame burns. Second one is scalds. And another one is, sometimes even extreme temperature of cold can also cause burns. So that is nothing but cold burns. Right? Next. Based on the voltage, electrical burns are again divided into low voltage and high voltage. Then chemical, again you have acid and alkali. Right? So these are the different types of burns depending upon the mechanism that is involved, right? Next, what are the different methods of assessment of burnt area? Let's imagine this scenario, you are in the casualty, the patient arrives with the thermal burns. There are different methods by which we need to assess the total burn surface area. It's called TBSA. Okay, so TBSA nothing but total burn surface area. Okay, so what are the different methods to assess that? The first one is it's a crude method where we will take a piece of paper and we will measure it according to the palm of the patient, the size of the palm of the patient. That roughly corresponds to 1%. This is called palm method. But this is not an ideal one. Okay, right. Next one is what we routinely follow in our clinical day-to-day practice is that it is goes by the name Wallace rule of nine. Rule of nine. Okay, I'll explain what it is. Then next one is in children, the best assessment method is Lund and Browder chart. Lund and Browder chart. Okay, right. These are the different methods of assessment of TBSA. But let's look at this Wallace rule of nine. It is nothing but it is different for adults and children. So let's say you are having, okay, there is only one difference between adults and children. So in adults, head is 9%, each upper limb is 9%, anterior trunk is 18%, and posteriorly you have again 18%. Means the anterior chest 9, posterior chest 9, anterior abdomen 9, posterior backside 9. Then both upper limbs are both upper limbs are in adults it is 36%. That means each lower limb is 18% and genitals is 1%. Okay, so this constitutes 100%. The main difference between adults and children is in case of children the surface area of the head is very high. So in children this 9 becomes 18 in case of children. Okay, right. And where is this extra 9 coming from then? This extra 9 is coming from lower limbs. In lower limbs, in children, it constitutes only 27%. This becomes 27% in children. Okay, right. Next, what is modified Portland formula? In the first place, why should we assess the total burn surface area? Why should we bother about percentage of the total burn surface area? That is to resuscitate the patient. One is to resuscitate the patient. We need to calculate how much fluid should be given in the first 24 hours. And the burn surface area is also important to assess the prognosis of the patient. Okay, so What is modified Parkland formula means? It is nothing but 4 into weight of the patient in kgs into total body surface area bond or total bond surface area. Let's say this will give you some ml of the fluid. Out of this, we need to infuse the fluid. So we will divide this whatever the ml that is coming here. We will divide that. So the first half of the fluid is given in first 8 hours. Then the second remaining half volume will be given in the next 16 hours. Okay. So first 8 hours, then next 16 hours. Another important point you need to remember here is from which time we are calculating this time means it is the time of occurrence. Let's say, for example, the patient arrived in the casualty at around 6 p.m., but the actual incident occurred at 4 p.m. You need to calculate the fluids in the first 24 hours starting from the time of occurrence of event, not from the time of arrival of the patient. Okay, right. Next. Can we give colloids straight away on arrival of the patient? The answer is no. Why should we not give colloids in the first 24 to 48 hours? Because the main pathogenesis in burns is there will be third space loss. What do you mean by third space loss? So, this is the intravascular compartment you have, and this is the cell you are having. So, in first 24 to 48 hours, there will be increased endothelial gaps. So whatever you try to give the colloids, it will extravase it. Okay, so it will go into the interstitium. That is called third space loss. Hence, we should not give colloids in the first 24 to 48 hours. Okay, right. Next, what is curling ulcer? In case of severe burns, please understand, curling ulcer is seen in case of only severe burns. So what happens here? Because of the severe burns, all the circulation will be diverted from the unnecessary or less important areas to the more important areas like brain, etc. Okay. So what happens here? Because of the ischemia. So because of the ischemia, there will be diversion of the shunting of the blood circulation that gives less blood supply to the stomach mucosa. Less blood supply to the stomach mucosa. Stomach mucosa is very sensitive to ischemia. So because of the decreased blood supply or ischemia to the mucosa, it will lead to stress gastritis. Okay. So this stress gastritis which is happening in case of severe burns is called curling ulcer. Okay. Then if this happens in head injury, the same is called Cushing ulcer. Okay, that is also a form of stress gastritis which is happening in case of head injury. Okay, right. Next, what are the different types of shocks seen in burns? So you need to understand here, because of the volume loss, the main important type of shock which can happen is hypovolemic shock. Okay, then next is because of the charring of the free nerve endings, you can have neurogenic shock. Then when the wound is not properly addressed and if it is not cleanly debrided, etc., it can go into sepsis and can lead to septic shock. So these are the different types of shock which can happen in case of burns. Burns is a very important topic. So this is just a brief overview about burns. So let's look at the next question. A 45 chronic alcoholic patient presented with epigastric mass, history of severe abdominal pain 2 months back. Now, on examination, mass was firm in consistency, moving with respiration. Imaging reveals well circumscribed mass of 15 to 10 centimeters posterior to the stomach. So, posterior to the stomach, this anatomical area is called lesser sac. This is called lesser sac. Okay. So this is a clear cut, straightforward question where patient is a non-alcoholic. 2 months back there was abdominal pain. Now he presented with epigastric mass, which is firm and moving with respiration, and which is present in lesser sac. So the most likely diagnosis is pseudocyst of pancreas. Okay, right. So this is the stomach we are having. Second part of duodenum, etc. This is the pancreas we have. So behind, whenever there is a communication between main pancreatic duct, because of the extravasation of the fluid and all, this is the posteriorly you are having a cystic lesion here. Okay, so this is the stomach and this is the cyst we are having, which will be most like just posterior to the stomach. It will be there. Why is it called pseudocyst anyway in the first place? Why is it not a true cyst? Normally, when do you say a cyst is true? When it is lined by true epithelium. Whereas the pseudocyst is not lined by true epithelium. This is just lined by a fibrous tissue. It is nothing but a granulation tissue. It's a firm, it's a collection of the fluid which is surrounded by a fibrous or granulation tissue. That is why it is called pseudocyst. Okay, right. Next, what is the treatment of choice? As you can see in this picture, this is the we are looking from the sideward direction. So this is the stomach we are having, posterior wall of stomach, and this is the anterior wall of stomach. So this is the stomach we are having, and posteriorly you have the cyst here. If it is present just in the head or body of the pancreas. Now we will anastomose this cyst cavity to the posterior wall of stomach like this by either laparotomy or endoscopy or laparoscopy. Okay, so this is anterior, this is posterior. So what are we anastomosing? Anterior wall of the cyst is anastomosed to posterior wall of the stomach. Okay, this is the anterior wall of the stomach, this is the posterior wall of the stomach. So this is called CG. CG is nothing but cystogastrostomy. Okay, this is the most preferred option. See, let's say for example, you are having the same cyst is present in the tail of the pancreas in relation to the tail of the pancreas. Obviously, in such condition, you cannot anastomose stomach to the cyst. In such condition, we will take a loop of jejunum and in Roux-en-Y fashion, we will anastomose it to the cyst. This is called Roux-en-Y cystojejunostom. This is another option we will go for when the cyst is present in relation to the tail of the pancreas. Okay, right. Next. But when do we go for surgery? What are the actual indications of surgery? So you need to understand whenever a patient is very much symptomatic and whenever there is any complications of pseudocyst, what are the possible complications you can have? One, it can enlarge in size. Okay. Second one, it can rupture. And the another complication you can expect is there is secondary infection of the cyst. Rarely, when it is enlarged and when there is high amount of enzymes which are producing because of the elastase and all, there can be pseudo aneurysm of the vessels which are present in the adjacent areas. And also, it can rupture into the GAT, which can cause upper GI hemorrhage. So these are the possible complications you can have. So whenever the patient is having symptoms or even complications, you need to go for surgery. But before you go for surgery, what are the main prerequisites or criteria which are required for surgery? Okay, so what are the prerequisites for surgery? It is called rule of six. Okay, so what is rule of six? Rule of six is nothing but you need to have at least 6 centimeter size of the cyst, then 6 mm wall thickness, because you need to the sutures need to be taken up properly only when there is wall thickness is adequate. And before that, the main one is duration, more than 6 weeks. Why more than 6 weeks? Because it gives the time for the cyst wall to get mature. Okay, so this is called rule of six, right? So when you have this proper rule of six, then only you will go for you will go for surgical intervention. Okay, right? And you have an important classification called Degidio classification. Okay, Degidio classification. And I have already described this Degidio classification in one of my previous videos. I'll give the link in description. Please do watch. Thank you.